Ian might remember, but I first met Ian at a CLEAR course, Clinical Evaluation and Literature Review. Is that what it still stands for? And research, sorry. And we had a good time at that. Poor Ian was doing his PhD in those days and had umpteen bits of data and difficulty, I think it was, and it wasn't as simple as it sounded. And for orthopaedic surgeons, it's a bit tough when you're doing your PhD, isn't it? But anyway, we thank Ian very much for coming today. He's pioneered many things across Australia and across the Tasman as well, and we look forward to hearing what you have to say. Thanks, Ian.
All right, well, thanks for having me. I'm the sort of fly-in, fly-out guy, I think. What I'm going to talk about is orthopaedic interventions in older patients, and it's steering away a little bit from what the last few talks have been, where it's really at the tail end. And my definition here is going to vary between sort of over 50, over 55, over 65, that kind of thing. And the topics I'm going to touch on are these sorts of interventions, and these are the big ticket items. So for joint replacement, currently in Australia, for hip and knee replacement alone, we spend between $2.5 and $3 billion a year, which is about between 2 and 3% of the whole health budget goes on hip and knee replacement. It's the number 1 and number 2, knee and hip items, followed by birth. Arthroscopy is another very common procedure in orthopaedics. And fractures, particularly in the elderly. So I'm not talking about young people, but it's the hip fractures, which we've talked about, wrist fractures and shoulder fractures. These are the big 3 that we treat as orthopaedic surgeons. And there's also spine surgery, because that becomes very common again in older patients with degenerative conditions, lumbar spine stenosis, back pain. And also we do a lot of injections, not just the orthopods, but a lot of injections in the spine. So I'm going to talk about those. Now, this is the framework that I work under, because I try and break things down so that I can understand them. And this is one way I look at it. We've got interventions, we've got patients, and interventions vary in effectiveness from the completely ineffective to the highly effective and in between. And you've got patients for any given procedure who are more likely to benefit than others. And the trouble is that this all doesn't line up. So you get, for example, effective treatments being given to patients who are likely to benefit from them. Great. You're also getting effective treatments given to people who are unlikely to benefit from them. And you're getting ineffective treatments given to everybody where it doesn't matter. And so we've got to kind of reduce all of this, and we've got to highlight the green line. And so the 2 areas of interest that I have are in the effectiveness of surgery, and not just the effectiveness, but the appropriateness of how they are applied if they are effective. So these are the 2 sort of broad areas, and this is the way I look at things. And so this brings you down, if you just picture that last graph, it brings you down to a framework that we can start to apply to surgical interventions. Now, we need to reduce or eliminate ineffective procedures, because they're no good, doesn't matter who you give them to. We need to evaluate procedures with unknown or uncertain effectiveness, and there's still a lot of them around. And when we have procedures that are effective, we need to apply them efficiently, what's called allocative efficiency. So we're going to go through each of these 3 topics. Reducing ineffective procedures. Here I'm just going to give you an example of something that we did in southwest Sydney. So this is South West Sydney Local Health District, and in 2011 the department head was looking at the evidence, and he said, I think we're wasting our time doing knee arthroscopies in people over 50. I'm sick of doing it because the patients come back and they're either worse or they're no better. I think it doesn't work. And so they looked at the literature, and South West Sydney, just to let you know, is a bit of background. It's a population of about 900,000 people, expected to be 1 million soon. It's one of the fastest growing areas in Australia. It's also a very low socioeconomic area, but it varies a lot because it's fairly big. And there's 5 hospitals in that area with orthopaedic services. Now, the head of department at 2 of those hospitals, those 2 hospitals are part of one unit, sort of elective and trauma. We did an evidence review, and we said, okay, we can't just ban procedures, that's not really good practice. But the department agreed that you can do arthroscopies on people over 50 if you want, that's fine. You just have to go through the head of department. And it's an interesting model because you just think, well, that's really not stopping them at all. And we did this once before years ago, and just to make a point, I'm not the head of department, so I wasn't the person that initiated this, although I work in some of these departments. But when I was head of department years ago, we had a problem with bone morphogenic protein, which sounds fantastic, but it wasn't very effective, and it cost a lot. And the company that made it upped the price from $4,500 per jar to $6,400, and I said, wow, and it doesn't even work very well, so let's stop using it. And some of the surgeons said, well, you can't stop using it, you know, what if we really need it? And I said, okay, well, you can use it whenever you want, you just have to ask me for permission. I won't, you know, I'm not going to stop you. It's just one little hurdle, a very small hurdle. Just send me an email, I'll say it's okay. Nobody did. So from that moment on, nobody used bone morphogenic protein. Except we did. We had one case of a patient with osteogenesis imperfecta with a non-union, so we used it. But there was one case. Ever since then, it's like 10 years ago or more. So we thought, well, we'll try that and see what happens. And interestingly, when we did that, one of the other hospitals, remember there's 5 hospitals in the area, one of them said, yeah, okay, we're on board. And the other one said, you guys must be crazy, you know, I mean, knee arthroscopy is what we do, it's our number 1 procedure. You can't just not do them on people over 50. And we said, well, it doesn't work, so that's a good reason. And they said, oh no, that's crazy. But then that same person came to us about 6 months later and said, you know, I've been looking at my results, I really don't think they're that good. And I think we'll follow. So we had 4 hospitals follow, and what happened, so I'm giving you the long version of this story, but what happened in the 5th hospital, I never approached, you know, we never approached any of these hospitals, it was all just sort of voluntary. But the general manager of the 5th hospital heard what was going on and called a meeting with the orthopaedic surgeons at the 5th hospital and rang me up and said, can you come to a meeting? And I didn't really know what it was about. And I said, sure, I get asked to meetings all the time, so whatever. I'll just phone it in. And little did I know that when the meeting started, he's going, okay, we're going to ban arthroscopy in this hospital. And I'm like, oh no, don't go down this path. And the orthopaedic surgeons at the other end were very hostile, I can tell you. And they had their studies and they had piles of papers there, they were ready to go. And they said, we've got studies here that show how good it is because, you know, case series and things like that. And I just backed down. I said, look, I'm not going to tell you guys what to do. If you want to do arthroscopies, you know, that's fine. And they were, you know, so vehement, they actually said, you know, not only are we going to do arthroscopies, we're going to do more arthroscopies than we've ever done before because we think they're underdone. I'm going, okay, fine, you know, whatever. And so 4 hospitals joined this, and the 5th hospital did not. And so we got data from the Bureau of Health Information in New South Wales. We looked at the 10-year data. We looked at private and public. We looked at everything. And these are the results. So we looked at data on over 12,000 knee scopes in people 50 and over. Press the wrong button. Yep. And about a quarter of them, nearly a quarter of them done in public hospitals, most are done in private. So that's why we had to look at both. And we found a peak in both at 2011. Which is when we introduced the policy, and it decreased by about 1/3 in the 2 years that followed. Now, interestingly, there was a 40% decrease in the public, and the argument's going to be, well, yeah, you're not doing it in the public anymore, the patients are just going to go to the private. There was a 25% decrease in the private, and there was no increase in the outflows. So people who lived in southwest Sydney who went somewhere else, no change. So, and this decrease was greater than any other local health district in New South Wales, but interestingly, they nearly all fell from 2011. There's a general trend. So if you look at New South Wales, there's a slight fall from 2011. If you look at Australian data, there's a slight fall from 2011. That's southwest Sydney, and the big blue bit is private hospitals, big decline, public hospitals, big decline, and the orange bit is the outflow. They're people that live there but get operated on outside our area. So that's a pretty big difference. We're actually just doing the 2015 data now. We're hoping it's going to get to the 50% reduction mark. And these are the 5 hospitals. And just to point out here, there's a crossover here at 2008. That's because this hospital shut down and all the patients from this hospital went to this hospital. So if you add them together, it's almost a smooth line. And you can see there's this fall from 2011. Now my question is, which one of these hospitals is Hospital 5? Hospital 5 is the blue one. Hospital 5 had as great a reduction in knee arthroscopy than any of the other hospitals. Now there may be explanations for that. Certainly there were some surgeons that retired in that time and some younger people came on board. I don't know. But interesting. And so if you look at, this is Australian data, if you look at the rates of knee arthroscopy in the over 55s, which is what this is from the Atlas, you see Fairfield, which is one of those hospitals, and these are all sort of South and West, Southern Highlands, another one, have the lowest rates in the country. You'll be pleased to know that Queensland is not bad. South Australia and Western Australia consistently have the highest. And now the difference is about tenfold between areas, because it's not decreasing much in those areas. So how does this work? I think you need clinical leadership as an initiator, as an enabler, and it allows surgeons to change practice through the usual methods. Now, what are the usual methods? How do surgeons actually change practice? Well, I point you to this article. It's worth chasing up. It's a bit of a heavy read, but it looks at what are the drivers of variation in orthopaedic surgical practice. What makes surgeons decide whether to operate, not to operate, or to change their practice. And there's recurring themes that come up here which really ring true to me. But knowledge in the form of clinical guidelines plays a very small part, and I think we know that. What does is things like this on the right-hand side. What my mentor taught me, if I just keep doing what I'm doing, it just, whatever burns fewer bridges between colleagues, whatever others are doing, you know, that's what I'm going to do. Don't rock the boat. And it's more colleagues, opinion leaders, what I learned at the last meeting kind of stuff, rather than, so it's what we call medical socialisation. People change socially. They don't trust RCTs from outside their group, which is why many of the RCTs I do involve 20 or 30 hospitals, because then it's more likely to result in change. And decisions made locally by a core group of professionals have legitimacy and are believed, and that's exactly what we did in this case. These other sort of recurring themes, patients in research don't match patients in real practice, I hear that all the time, and surgeons believe that surgery works in my hands. So, let's change tack a little bit and look at what to do with procedures of unknown effectiveness. And the big question here is, how do we determine effectiveness in surgery? And one of my sort of main thrusts is that we don't determine effectiveness very well. We don't do it very reliably. We determine effectiveness based on observational data, and normally based on our own observations. And the support that underpins much of the surgery that we do today relies on observational data, animal studies or lab studies, which are not necessarily applicable, and I'm having a mental blank. Observational data, lab studies, and a biologically plausible mechanism. And that to me doesn't cut it, because you can think up a biologically plausible mechanism for just about anything. And I learnt that when I studied, read about antidepressants and the selective serotonin reuptake inhibitors and how they cured depression, and then they didn't all of a sudden, and then they found out that the selective serotonin reuptake enhancers, which have the exact opposite effect, have exactly the same effect on depression, which isn't much. So you can think up biologically plausible mechanisms for just about anything. And the other thing is that the person who's making the decision is largely the surgeon. And the literature has shown us over and over that surgeons overestimate the effectiveness of surgery and underestimate the harms. They do it consistently. We've looked at it for tibia fractures. We've looked at it for joint replacements. You ask the surgeon, how'd the patient go after that tibia fracture? And they say, 70% of the time they're satisfied, 77%. The patients, 44% are satisfied. It's a complete overestimate. Same with joint replacement. So we have a problem where we have overestimation of benefit and underestimation of harm, and this really is the thesis that runs through this book that I wrote, which you should all buy, and please pay full price. And this is really what the book's about. So if you are interested in it, then read this further. It's got a sensationalist title, Surgery, the Ultimate Placebo. It was originally written sort of surgery as placebo. I thought it sounded a bit more highfalutin or something, and the publisher named it that. And I went into a philosophical argument with the publisher about whether if we were sensationalising the argument, then does that underpin my argument that surgery is sensationalised? And when I was in the middle of this discussion, the publisher said, "Did you want to sell the book?" And I said, "Yes, I want to sell the book." And I said, "Well, we're going to call it this." So that's how the name came about. But in it, I discuss a lot of these things. Like, this is the first randomised trial done in surgery, which was for angina. Now, biologically plausible mechanism, okay? Angina is not enough blood going to your heart. If you tie off a blood vessel that branches from the ones going to the heart, the blood will be diverted to the heart. So doctors tied off the internal mammary artery, biologically plausible mechanism. Animal studies, they tied off the internal mammary artery of a dog and found that the blood didn't go through it after they tied it off. It went towards the heart. Okay, animal support. And the third thing is observational data. So they got some patients. They tied off their internal mammary artery and their angina got better. So they did the operation. They're the three things that underpin most of what we do, and it's complete rubbish scientifically. If you get a physicist from CSIRO come here and say, "This is the evidence we have for surgery," they would faint with a lot of the stuff we do. So they did this in 1939. It was done across America for 20 years. And in 1959, they published a study where they tied off the internal mammary artery in some patients, and the other ones they did a thoracotomy, put the suture around it, but didn't actually tie it. They found they got exactly the same results. Yeah, they got better. Patients felt better because they'd had an operation. But it was no different with whether you tied it or not. And there's so many examples of this. This is Parkinson's disease. Okay, biologically plausible mechanism. It's a lack of dopamine in the brain. Let's take some cells from a fetus that make dopamine and stick them in the brain. Let's do some studies where we dissect the brain afterwards and we can see that cell lived. So it makes sense, it works. Let's do it on some patients, they get better. Now let's do a scientific study where we put the cells in some patients, we don't put the cells in others, and there's no difference. So that's how you determine effectiveness. There's so many more examples. This one's a classic because people who are doing this closure of a patent foramen ovale, where the blood goes from the right side to the left side or whatever, people said their migraines got better afterwards. So then they got the mechanism, and they biologically plausible mechanism. They said, yeah, something from the right side is getting to the left side, and then it's going to the brain, and that's what causes migraine. You know, they didn't think that migraine is episodic, not constant. It's focused, not widespread. So it really doesn't make any sense at all, but it kind of sounded good on first pass. And that's really all it takes. So people started doing this to treat migraine. They got great results. Right? Then they did a study where they compared doing it to not doing it, and they found it made absolutely no difference whatsoever yet again. More examples I'm not even going to talk about because I want to get through the rest of the study. Shoulder pain, any cause for shoulder pain. They just finished a sham surgery study in the UK, which is about to be published, looking at sham surgery versus real surgery for decompression in the shoulder. Which is likely to show no improvement because the non-sham studies showed no improvement. And humeral neck fractures is another really common one. And that's where a recent large study showed no improvement with surgery over non-approved treatment. Knee pain I've kind of touched on. So let's keep moving. How do we explain this perceived improvement? Because the surgeons come to me and they go, but my patient said they got better. Well, there's two reasons why you can get perceived improvement. One is because they did get better, and one is they didn't get better, they just sort of thought they did. The trouble is, if they did get better, they often got better, but it wasn't due to the surgery. And sometimes they think they got better and they didn't really. So I'm going to cover those two topics now. So getting better, but having it not due to the surgery. This is the classic logical fallacy that we all fall for. It's this association versus causation. So here's a map, and you can download heaps of these. There's whole websites devoted to correlation is not causation. And this is polio cases versus ice cream sales in 1949. Now you can think up a biologically plausible mechanism to say that ice cream carries a virus, or ice cream makes your throat cold and lowers your resistance to it. You can think up anything you want. Biologically plausible mechanism to me means almost nothing. If you can't find a biologically plausible mechanism for something, then you're in trouble. If you can, it doesn't mean it works. And of course, the common element here is summer. Polio cases and ice cream, both sales go up in summer. So this is the fallacy called posthoc ergo propter hoc, which is Latin for it follows, therefore it is because of. And this is a human response. This is what got us here evolutionarily. This is a shortcut that we make, and this is what we call conclusion jumping. And we do it all the time. We see somebody get better and we assumed it's due to what we did, but often it's due to the natural history. This is why every single treatment for the common cold that has ever been offered in the history of knowledge works. Because everybody got better afterwards. Regression to the mean, more difficult to describe, but it's a common reason why people get better. And just fluctuating conditions. You're treating migraine, you're treating pain, you're treating osteoarthritis. These things fluctuate. Osteoarthritis of the knee, you have a good day, you have a bad week, you have a good month, you have a bad year. It's all over the place. If you treat someone when they're particularly bad, and you do anything to them, they're going to be better afterwards. And this is what happens, and I've been with surgeons where patients have come back after a knee arthroscopy at 1 month, 2 months. No, my knee's still not better. And you sort of say to them, it's okay, it takes a while to work, which is just crazy. And they come back at 7 months, is it better? I think it is a little better. There you go. The surgery worked. And of course, concomitant treatment. And the reason why people often feel they get better is because they have to pass through this therapeutic envelope before they become a treated patient. They come in as a person and they have to go through the whole environment, which has all sorts of things like the interaction, and we all know how important the interaction between you and the patient is. You need randomised trial. You need high-level evidence, particularly if you're talking about subjective things. So we did a study looking at, what is the randomised trial support of orthopaedic surgery? So we looked in southwest Sydney at 3 big hospitals, and we looked at over 9,000 procedures, all the orthopaedic procedures done in those 3 hospitals over 3 years, and we found that we looked to find how many of them have been subjected to a study comparing them in a randomised way to non-operative treatment, surgery versus no surgery. And we found about half of them, was about 51% of the procedures had been subjected to a study comparing them to non-operative treatment. And that's not unusual. If you look at paediatric surgery, I think gastric and a lot of other things, it's around about 50%, 40 to 60% of things that we do have been subjected to randomised trials. So that's fine. I didn't have a problem with that part. The problem I had was that in that 50% that had been subjected to randomised trials comparing them to non-operative treatment, in about half of those, the randomised trials showed that the surgery was no better than non-operative treatment. And yet we were still doing it. That's the problem I have. And so you get this situation here, and this is the sham surgery study on arthroscopy for MRI-proven meniscus tear without arthritis. And this is showing the difference between the sham group and the real group. It's the same, right? There's no difference between the two. Now, the problem I have with this, and this is the best level evidence we have, I mean, I used to do arthroscopies on people with sore knees all the time, and I thought they got better. And then when I started looking at the evidence and I looked at the patients that I was still doing, I thought, gee, they're really not that much better. So it really depends on the way you look at it. This is objective evidence. Now, the problem I have with this is the number in the top right. Have a look at the top right of the screen. This number here. Okay? We have been doing arthroscopic partial meniscectomies since the 1970s and 1980s. This is the problem I have. Why does it take 30 or 40 years to do a study? Shouldn't we be doing the study when we introduce it? Not 30 years and possibly tens or hundreds of millions of operations later? but we're still doing it. This is the rate of spine surgery in Australia, increasing. Spine injections is another one. I haven't got time to go into this too much, except to say that when you look at the evidence for epidural steroid injections, no matter how you give it, whether it's transforaminal or sideways or facet or whatever you do, when you look at the evidence, it's not very convincing. Maybe there's a small effect, subclinical effect for a few weeks. When you look at the evidence that involves sham, it's even less. When you look at the really high quality studies, it's nothing. So there is no evidence for what we do, and yet you look at the numbers of epidural steroid injections being done in Australia, and that's what's happening. So there is evidence, but we're still doing it. So why do we still do things when the evidence shows that they don't work? And one reason is because we believe them to be effective. I think that that's true. These ones, however, I don't buy. People say to me, well, patients want it. You know, I don't buy that at all. I see patients all the time. They come in with the 80-year-old with an MRI of the knee saying they want an arthroscopy. And I say, well, you don't need an arthroscopy because it won't help you. And they go, oh, good. I would be stupid to want one if it wasn't going to help me. You know, they don't demand it if it doesn't work. That's crazy, and that's really underestimating the patient's intelligence. The other argument I get is the failure of non-operative treatment. Well, patients have tried non-operative treatment, therefore we need to operate. You go, yeah, that makes sense. Hang on a minute. Things often make sense on a superficial level. You know, they've tried non-operative treatment, didn't work, we operate. Think of it a different way. Okay, you've got an operation that doesn't work. Okay, does the failure of any other treatment suddenly make that effective? No, that operation doesn't work. The fact that they've failed 10 other operations or 100 operations or non-operative treatments doesn't make that work. It just doesn't work. So I don't buy that argument either. The lack of alternatives, again, this is narrow-minded. People say, well, if I'm not going to do an arthroscopy, I'm going to have to do a knee replacement. No, you just don't do anything. You treat them non-operatively, and a lot of surgeons have difficulty with that. The other argument I get, believe it or not, and I know that time's going over, so I'll rush through the rest of it, but I've actually sat down at dinner with orthopaedic surgeons, and they've said that study that I showed you before on arthroscopy versus sham, that's the best study ever, and I do more arthroscopies than ever now. And I'm like, okay, you got me interested, right? You know, please explain. And they said because 2/3 of the patients got better. And I said, yeah, but they were no more likely to get better than if they pretended to do an arthroscopy. He's going, I don't care how it works. If 2/3 of my patients get better, I'm going to keep doing it. And I didn't really have time to point out all the problems with that with him because we were enjoying a nice meal. But I'll point them out to you. The problems I have with that is, apart from the cost and the risks and the deceit, is as soon as we start embracing that, as soon as we say we don't care how it works, we're just going to do it anyway because people seem to get better, then you've just removed the only barrier that lies between mainstream medicine and alternative medicine. You know, do you think homeopaths, which are peddling nothing, they are peddling water, do you think that they go home at night and go, oh, I fleeced another couple of customers today, you know, and I made a few $1,000 selling this water. It's fantastic, you know, what a scam. No, homeopaths believe that it works. So this is the main reason. This is what drives us and why we still operate. And so very quickly, I'm going to skip through about 40 slides in 4 minutes. Talking about applying effective procedures efficiently, and we do this. If you look at joint replacement, it's an effective procedure and we do apply it efficiently. We measure the results, and the revision rates now for a good knee or a good hip, some of the best hips and knees, the revision rate at 15 years is less than 5%. I mean, these are very hard numbers to beat. But if you look at some other things, the revision rates are a bit higher in unicompartmentals, but the rate of unicompartmentals is falling. Because we're measuring it, this is all data from the joint registry, we're changing practice. Look at this. Cementless total knees don't do as well as the others. So what's happening? We're doing less cemented total knees. We're changing practice. We're making things better. We only know we're making things better because we're measuring it and reporting the outcomes. Here's another one. We know that XLPE, cross-linked polyethylene, works better. So we're using more of it, and therefore the results are getting better. This is really simple stuff. Another criticism we get though is, we're doing too many total knees on young people, and we know the results aren't as good in young people. But if you look at the proportion of young people under 55 that had a total knee replacement in 2003, it was 7%. In 2015, it's 6.8%. It hasn't gone up at all. So we're doing this, and we're applying it responsibly. We're measuring now patient-reported outcomes. We're now down to better than less than 5% loss to follow-up. And we can tell you inter-hospital variations. Look, admission to HDU between these 8 hospitals. This is the transfusion rate between these hospitals. What did this hospital do? They reduced their transfusion rate. They only knew it was a problem because we were measuring it. This is the referral to inpatient rehab after joint replacement. One hospital, it's about 2/3 of patients. In another hospital, it's about none. There's huge variation. We've done randomised trials to show that this has no benefit whatsoever. So we need to stop doing it. And we are. But these are effective procedures. You take patients who have severe problems with walking pre-op, and they've got no problems with walking post-op. You can map it differently. You get patients with poor Oxford's hip scores pre-operatively, and they're largely going to excellent afterwards. It's a good operation. But there's more we can do. There's psychological factors, there's predictors that we're working on. So what we're talking about is changing practice. We're not sitting here, you didn't come here to this room to do things the same. We've always got to change, we've always got to improve. And this is the 3 ways that we do it. We reduce ineffective procedures, we need to evaluate those of unknown effectiveness, and we need to apply effective procedures efficiently. And the keys to practice change are interesting. It's not just putting up a set of guidelines. Practice change occurs slowly and occurs through social mechanisms. It actually occurs by line of sight, which is very interesting. And that's why when you see all these trends in the joint replacement, how things are getting better, it's slow. They're getting better a little bit by little bit. But that's the way change occurs. Quality scientific evidence will always change practice eventually, but the process by which this occurs is social. I might stop it there if that's okay. All right, thank you.